T4 is free. Some of it is bound by TPG. TPG has binding sites for thyroxine, T4. It is not always saturated, right? So at any given time, this much of it, say this is all there is, 1, 2, 3, 4, this is 10 binding sites. This is about 60% bound, right? Mm-hmm. And he had 40% free sites. This is inside the patient. How do we know? What we really want is to find out what percentage of this total T4 is free. We can't measure it directly. We have to look for an indirect way to measure it. What do we need really to estimate it? Well, if we can figure out what TPG binding percentage is, right? And what the unbound percentage is, that unbound percentage times the total T4 is what the free T4 is, right? So how do we get there? So they came up with this smart idea. So you get T3, the radioactive T3. You put it there. You know how much you're putting, right? So that radioactive T3, some of it will bind to this 40% site. But you don't know it's 40%. You only know it will bound. You now put resin. This resin is going to catch any free unbound radioactive T3 that you added. So depending on this resin T3 uptake, you can estimate how much of the T3 was bound. You got it? Yeah. So generally speaking, if somebody has high T3 uptake, that means less of it was bound, and that means more of it was free. You got it? Mm-hmm. Okay, so that just for you to know, because you will see it in many thyroid function tests, T3 uptake, and then you need to know what it is and how it is determined. So this was where we stopped last time. This morning, I hope to finish this thyroid overview in the first hour, and then the last 2 hours we'll do parathyroid. Then you'll be ready for your midterm. Right? Good. So it's important that you understand everything I said today because you won't have time to review it. Okay, so let's get to business. So you remember I told you last week that whenever you want to find out what is going on with somebody's thyroid, is this working now?
Yeah, I tell you batteries.
Thank you. Right? You always look at TSH. If TSH is high, then you look at free T4. This is true for every endocrine problem. You have to know the driver and the target organ. So if you have high TSH and low free T4, well, that means the patient is hypothyroid, and the high TSH is a response to that hypothyroidism, right? And I also told you that you can find this in thyroiditis. You know the way you get laryngitis, viral illness, you can also get thyroiditis like that. Okay. In the acute phase, you tend to release stored thyroid hormone. That is why it will give you transient hypothyroidism. But in the chronic phase, when the thyroid gland is now healing, it will give you a picture of hypothyroidism. And I also told you to be very careful. This is a very common clinical situation where you have high TSH and normal free T4. Whenever you see this discordance where TSH is high and free T4 is normal, in fact, whenever there is a discordance between TSH and free T4, that is a subclinical situation, right? When TSH is high and free T4 is normal, you call that subclinical hypothyroidism. Because under normal circumstances, if this free T4 is normal for the patient, TSH will be normal. The fact that the TSH is high means the patient really needs more free T4 than the patient has. That's why we call it subclinical hypothyroidism. The reason it is called subclinical is because the patient is not showing signs and symptoms of overt hypothyroidism, but the test is suggesting it, right? And then when you have high TSH and high free T4, that is what pituitary hyperthyroidism is. So it's important for you to understand how to do this. And then, of course, the flip side of the coin is this other one here. Again, when TSH is low and free T4 is normal, that means this free T4, even though it's normal, is excess for this patient because it's suppressing TSH. That's why it is called subclinical hyperthyroidism. You got that? Okay, so moving on. So now we're going to talk about hypothyroidism and hyperthyroidism. Hypothyroidism is so common, my goodness. And the commonest cause of it is Hashimoto thyroiditis, which is an autoimmune thyroiditis. Okay? Outside of the United States, because it could be due to iodine deficiency. We don't see iodine deficiency in the US because we have iodine table salt, right? So outside of the US, you can find it as a cause of hypothyroidism. And then there are many iatrogenic. What does iatrogenic mean? Dr. Costin, right? Okay. Took somebody's thyroid out, they give radioiodine therapy or PA Costin. Or they give radiation or surgery and you burn out the thyroid, it can cause hypothyroidism like that. And then there are medications that interfere with the ability of the thyroid gland to release thyroxine. Lithium and amiodarone. Right? Remember amiodarone? Good. And then all these infiltrative diseases like hemochromatosis, iron overload, amyloidosis, sarcoidosis, they can interfere with the ability of the thyroid gland to make the release of thyroid hormone. And then, so these are the primary causes. Primary hypothyroidism is hypothyroidism due to thyroid disease. Secondary hypothyroidism is hypothyroidism due to pituitary disease. Okay? And that will be caused by tumor. This list is going to be common to all secondary stuff we're going to talk about. So pay attention to it. Tumor trauma infection, pneumocystis, TB, toxo, histo, infiltration, hemosarcoid, histiocytosis, and vascular disorders. Sickle cell, remember that? And remember pituitary apoplexy?
Yeah.
Okay. Remember shake hands?
Pregnant women?
Postpartum hemorrhage, pituitary infarction. Okay, remember that. Excellent. How does it present? Patient is tired all the time. They are very sensitive to cold. They may have memory disturbance or poor concentration. They lose hair. They gain weight, or they have difficulty losing weight. Anorexia, constipation, hoarseness. They have menstrual irregularities. This is a long list, right? Many of it non-specific. But there are some really specific symptoms here. Hair loss. Not just any hair loss. Especially if you look at somebody, well, it's difficult now that many women are shaving their eyebrows. But if somebody is not shaving their eyebrow and they lose lateral third of their eyebrow, that is a very reliable sign of hypothyroidism. So hair loss, especially lateral eyebrow, lateral third of the, so you divide the eyebrow into three. The outermost one is usually lost in patients with hypothyroidism. That is number one. Number two, see, cold intolerance is specific for thyroid disorders, right? Fatigue is not, memory disturbance is not, poor concentration is not. Hair loss, yes. Weight gain, not specific. Constipation, not specific. Hoarseness, yes. Okay? And that is usually due to myxedema of the vocal cord. That is in advanced cases. Myxedema.
Oh.
Yeah, you know we used to call hypothyroidism myxedema. Myxedema is, well, there is an abnormal protein that accumulates in soft tissue in patients with hypothyroidism. I've forgotten the precise name of it. That is what is called myxedema. It basically means the accumulation of this abnormal protein. It's called, I've forgotten. I didn't think I would explain it. But you find it. Huh? It's some kind of protein or sugar. pre-tibial edema in hypothyroidism is the reason you get hoarseness in the vocal cord. What you see in the tibia that we call pre-tibial edema is the same process in the vocal cord that gives you the hoarseness in patients with hypothyroidism. I think it's one of those aminoglobulins. So, in terms of specific signs, cold intolerance, hair loss, hoarseness, those are the really specific ones. These other ones are not that specific. Now, what are the signs? Dry, coarse skin, cold extremity, puffy face. Puffiness in the face is not necessarily specific. Bradycardia, yeah, but not really specific. Hung up reflexes, yes. You know what hung up reflexes are? So, you know, under normal circumstances, right? If you do a knee jerk on a patient, you see it like this. Usually the patient responds like this. Up and down. When the reflex is hung up, it's like this. Right? So it's like the relaxation phase is slowed. So if you do the arm, say you tap, it goes like that. That's normal. When it's hung up, it's like. So the relaxation phase is slowed. So we call it hung up reflex. Okay? There is a very specific sign for hypothyroidism. Okay? And of course, I already told you about the loss of the eyebrow. And then the non-pitting pre-tibial edema that I just told you is mixed edema. Okay? You got that? So what do you do when you see a patient with hypothyroidism? Of course, you do thyroid function test. Because of cost, many HMOs and many doctors are falling for this. They will just order just TSH. And with TSH alone, they make diagnosis. Don't do that. Do the complete panel. You know, at least do the TSH and the T4, so you understand what is going on. So you measure TSH. If TSH is elevated, then if you're in the United States, of course, you will do this on bound creatine core. But most of the time in practice, you will see the test you should order, they usually give you two options. One is TSH by itself. One is thyroid panel with TSH, or thyroid panel without TSH. When you do a thyroid panel, it gives you total T4, T3 resin uptake, gives you TSH. That's the panel. In order to save cost, people do TSH alone. Don't do that. Just measure panel. So measure TSH and then you measure the amount T4, which is your free T4. If your free T4 is normal, these people say mild hypothyroidism. What should it be? If you have elevated TSH.
Oh,
Exactly. So there is nothing like mild hypothyroidism. Clinically, it does not make sense. When is it mild? How do I figure out when hypothyroidism is mild? There is nothing like that. If the patient has symptoms, it's hypothyroid. Doesn't have any symptoms, it's subclinical. Okay, so they call it mild, but that really should be subclinical, right? If free T4 is low, that is your primary hypothyroidism, right? Now, there are many causes of primary hypothyroidism, right? But the commonest one is Hashimoto, right? So what you want to do also, which you will not be able to do, because nobody's going to pay for it, is to measure TPO antibodies, okay? And what is TPO? What is TPO? Huh? Thank you. So antibodies to thyroperoxidase, you will find out that is usually positive in patients with Hashimoto. So if you have primary hypothyroidism and you want to really confirm that in Hashimoto, you should do TPO antibodies. But, what does it, why do you need to know it's Hashimoto versus iatrogenic? Does it matter? What, at the end of the day, what are you going to give the patient?
Legal.
Levothyroxine, exactly. So it does not matter. That is the reason many health plans don't pay for this test. Okay, so you only see it in exam, right? Because it does not matter to, it does does not matter. It does not have any therapeutic significance whether you specifically diagnose Hashimoto versus other causes of hypothyroidism. You understand what I'm saying? Okay. So we do that to figure out if it is Hashimoto, right? Now, TPO, is it really that specific? No. I gave you this information here. 2% of euthyroid men and up to 15% of euthyroid women will give you positive TPOs. Okay? So it is not just because somebody has TPO doesn't mean, oh, they have Hashimoto's. No. Up to 15% of euthyroid women will have positive peroxidase antibodies. Okay? And thyroxine peroxidase is an enzyme, you know that. Okay? So if you do TSH and TSH is normal in somebody that you think really has clinical signs of hypothyroidism, if the TSH is normal, you have to think that this might be a pituitary disease. If you think somebody has hypothyroidism and you measure TSH and TSH is normal, you look at them closely for evidence of hypopituitarism. Like I told you, if somebody takes out a pituitary, they will suffer a lot more than just hypothyroidism. So you do a complete review of system to make sure you're not missing secondary hypopituitarism, right? If your unbound T4 is normal, you don't need anything else. You need to look for other reasons why the woman is losing hair and why she's having cold intolerance. But if it is low, then you should begin to think about other causes of normal TSH in somebody that is showing signs of hypothyroidism. You see this side of this table here? I couldn't cut it out. That's why it's here. This is not the way you practice medicine. Okay? This is not the way you practice medicine. Generally speaking, hypothyroidism is something your patient comes usually with symptoms, right? Or they are completely asymptomatic and you're just screening for it, right? So most of the time, it is, if your TSH is normal, both will stop right there, okay? So just put a circle around this and put a question mark. So you don't waste your time trying to understand it, okay? How do you treat hypothyroidism? You replace thyroid, you replace the hormone. And this is exactly how you do it, right? I'm giving you all kind of preparations of thyroid hormone, because you will see some patients that are these nature freaks, right? They want everything natural. Give them amothyroid. You don't need prescription for that. Okay? But you are clinicians. You will use levothyroxine. Okay? And I'm giving you here, even though we are supposed to use this in practice, most of the time we all start patients on 100 microgram if they are under 60, and you start at 50 microgram if they are under 60. Because old people are very sensitive to thyroid hormone. So you start low in the elderly, right? And then you just monitor them every 3 months. You monitor TSH. And what you want to do is to give enough levothyroxine to get TSH to be normal. And when you're giving too much TSH, you begin to, you're giving too much levothyroxine, you begin to suppress TSH. Then you need to back off. Okay, so that's why you always give it. Once at the beginning, you will do the thyroid function test every 3 months. Once your TSH is normal, you stop. Then you do it every year. If at any time you see TSH is beginning to go down, and your patient that is on levothyroxine, that means you're giving too too much. That is an iatrogenic hyperthyroidism. Okay? Yeah.
If your patient's subclinical and they're not presenting with like symptoms, do you usually just find it just by like routine screening, or like, 'cause no one really goes and says, let me test your, at least for me, no one's ever asked me to test my thyroid function.
No, you will.
But, so how would you?
In the elderly,
Yeah.
you always, or somebody, when somebody is overweight or they are on weight loss regimen, thyroid function test is a standard. Right? Yeah. So you monitor it, you just follow it, but you don't treat subclinical hyper. Okay. Excellent. Now, when somebody is on levothyroxine, you have to watch their other medications because thyroid hormone interfere with a number of other medications that are commonly used. See, beta blockers. The action of beta blockers may be impaired. So your beta blockers may not be as effective as they could be in somebody with hypothyroidism and who is taking levothyroxine. If somebody is taking bile acid sequestrants like cholesterol, you have to educate the patient. They cannot take those two medications together because cholesterol will bind the levothyroxine in the gut and the patient will defecate it out. It won't be absorbed. Okay, that's really important. Carbamazepine and phenytoin, they are anti-epileptic medications. They increase metabolism of levothyroxine. So you may need to start at a higher dose, okay, in somebody that is on anticonvulsants. And then the same thing, patients on birth control pills can show you weird results on thyroid panel because of increase in thyroid binding globulin associated with pregnancy and birth control pills. So be very cognizant of these medications. Digoxin levels decrease as hypothyroid patients return to euthyroidism. You know why that is the case, right? So if somebody on digoxin develops hypothyroidism, their metabolism slows down, right? So a little less of digoxin will be just fine because their metabolism is down. The medication will not be metabolized at the normal rate. When you begin to treat them and their metabolism picks up, that dose of digoxin that was okay for them will no longer be okay. So you can imagine if you're giving somebody, a very good example is somebody develops thyrotoxicosis, right? Hyperthyroidism, and they develop atrial fibrillation as a result of thyrotoxicosis, right? And you begin to give them digoxin, and you begin to treat the hyperthyroidism, and then you over-treated the hyperthyroidism, and you now drop the patient hypothyroidism, right? Well, the truth is that once they become hypothyroid, that dose of digoxin that you were giving them before will not be sufficient. Are you with me? I'm painting a very complicated picture here. The bottom line is, when you start treating somebody with hypothyroidism who is on digoxin, as their hypothyroidism improves, they may need more digoxin than you had them on before because of changes in their metabolism. That's the basic gist. You got that? Yeah. Excellent. Of course, lithium can cause hypothyroidism by inhibiting the synthesis of all that. So that is hypothyroidism. You see, it's very simple, right? Just need to do TSH and look at T4 and decide whether you're dealing with primary, secondary, or subclinical. Okay? And if it is primary, you treat it. Subclinical, you observe it. And when you decide to treat it, you pay attention to the other medication the patient may be on. Digoxin, theophylline, lithium, anticonvulsants. They all have some kind of interaction. You have to know exactly what to watch for. Any questions? You're good? All right. So let's talk about hyperthyroidism. Again, hyperthyroidism, look at the causes of it. It could be primary, it could be secondary, or it could be related to pregnancy. Okay? The one related to pregnancy is called gestational transient thyrotoxicosis. It is usually as a result of HCG-mediated TSH receptor stimulation. You know what HCG is, right? Human chronic neutropathy. It does have, when you have some time, take a look at the chemical structure of beta HCG and TSH. It's very similar. Okay? Very, very similar. So, beta HCG actually can stimulate TSH receptors to some extent. So in pregnancy, you get this transient neurotoxicosis. Okay? And sometimes, you all know about gestational trophoblastic disease? Okay. When the baby does not develop, instead, the fertilizer will just form into this tumor of pregnancy. Have you done OB?
Right now.
Okay, all right. Okay. So that I just want to do with that quickly. So primary hyperparathyroidism is your big deal. These are the causes of it. Thyroiditis, which is really could be as a result of injury or infection, usually viral. An ovarian dermoid, which is a thyroid secreting teratoma. You have nodular goiter. A goiter is an enlargement of the thyroid gland. Okay? It could be multinodular, could be many nodules, or it could be just one nodule. Okay? It could be iodine induced. What is that called? Iodine induced thyrotoxicosis. Joe Pastor, right? All right. But you know what? The one you will see more commonly, Joe Pastor. Remember we talked about that? Okay. Oh, you can't forget that. Yes, yeah.
Can you see goiter and hypothyroidism?
Yes. You can see goiter. You can see goiter in hypo and in hyper. Right? Remember when I told you about iodine deficiency? What happens in iodine deficiency is the thyroid gland enlarges to enhance its own ability to trap every atom of iodine in the body, available in the blood. Right? So the enlargement of the thyroid gland that we call goiter in hypothyroidism is usually due to iodine deficiency. It's an attempt of the thyroid gland to trap all the iodine you can get because it's so little in the environment. So you can get goiter in hypothyroidism. Okay? You understand it? Then, Graves' disease is an autoimmune thyroid disease like Hashimoto. The difference between Graves' disease and Hashimoto is that in Graves' disease, the antibodies are actually thyroid stimulating immunoglobulins. Whereas in Hashimoto, they are thyroid destroying immunoglobulins. They go against the gland. But in Graves' disease, they are antibodies that somehow are able to stimulate the gland. Right? So they call them TSIs, thyroid stimulating immunoglobulins. And then there is this condition called Hashimotoxicosis. Hashimotoxicosis is seen in a patient that starts out with Hashimoto, but then the antibody pattern shifts midstream. And instead of killing the thyroid, it begins to stimulate the thyroid. So the patient develops thyrotoxicosis even though the original symptom, original disease was Hashimoto. And then they transfer and become toxic. So it's called Hashimotoxicosis. And then there is thyrotoxicosis factitia. This is people that are taking natural thyroid hormones because they want to be on disability, qualify for some benefits. So they make themselves sick with thyroid, and they will come to you. And if you know what to do, you know what somebody is doing. I'll show you as you go down how you can determine when somebody is loading up on thyroid hormones. All right, now that is all about primary. Remember Graves' disease, nodular goiter in America. Remember those two. All the other, and thyroiditis. Oh yes, thyroiditis, nodular goiter, Graves' disease, very important ones. And then secondary is usually thyrotoxicosis that is due to a TSH secreting tumor. So it's a pituitary tumor that is secreting TSH, pituitary adenomas, right? And then there is another one called thyroid hormone resistance syndrome. This is an inherited resistance to T4 at the pituitary level. So you see, under normal circumstances, right? The pituitary gland releases TSH. TSH goes and stimulates the thyroid gland to release T4, right? And T4 goes back to the pituitary and says, I'm here now, you can stop stimulating the thyroid. But if for any reason the pituitary is not able to perceive or sense T4, it will keep stimulating the thyroid gland and the patient will become thyrotoxic, right? So it's very rare, by the way. Thyroid hormone resistance syndrome. You just need to know that that is possible. You will never see it because I have not seen it. And if you see it, you should write it up. How does it present? Look at it. Nervousness, palpitation, heat intolerance. They are hot all the time. They sweat a lot. They lose weight. They eat a lot. They defecate a lot. They have this, in Graves' disease, they have bulging eyeballs, muscle weakness, loss of libido, and oligomenorrhea. What is oligomenorrhea? Few cycles. Okay. What are the signs? Tachycardia, pulse pressure, hyperreflexia, tremors. You don't have to demonstrate. How did they teach you to find out if somebody has tremors?
Over a paper, put a paper.
Thank you. Put it on their hand and you can see the paper. The paper amplifies the tremor so you can actually see the amplitude of it. Okay? Goiter. Now, if you see somebody with hyperthyroidism and they have a goiter, listen up. Feel the goiter for tenderness. Very important. A tender goiter in somebody with hyperthyroidism is all you need to make the diagnosis of thyroiditis. If you miss that tenderness and you miss the diagnosis of thyroiditis, you will misinterpret the thyroid function test. Okay? And sometimes the activity, the metabolic activity in the thyroid gland is so high that when you put a stethoscope over the thyroid, you can actually hear the rush of blood into it with every beat. And that is called a thyroid pulling. And if the patient has been thyrotoxic for a long time, they may have clubbing of the digits. That exophthalmos, the protrusion of the eyeball that you find in thyrotoxicosis, again is due to abnormal accumulation of proteins in the soft tissue, right? It's not just about protrusion of the eyeball. They have a site called lid lag and lid retraction. Under normal circumstances, your upper brow covers the upper third of your eyeballs, right? So if I'm looking at you and you're looking at me, I should not be able to see the white of your eyeballs above the black of your eyeballs. So usually the lid covers the upper third. But when you have lid retraction, you will see the white of the eyeball above the black of the eyeball. You shouldn't be able to see that. Okay, so basically, I should not be able to see above your cornea when I'm looking at you because your upper lid should cover it. Okay? And then when you now tell the patients to follow your hand and you go up and down, you will notice that as the eyeballs moves, the lid lags behind the eyeball. So that is called lid lag. Okay, instead of the lid following down when the patient's eyeball is coming down, the lid will fall like, okay, say the eyeball goes like this, the lid goes So the lead lags. You could see the disconnection between the movement of the eyeball and the movement of the eyelid. You got that?
Yeah.
Okay. So these are important signs that they can throw in a question for you and expect you to make sense of it immediately.
Dr. Martins?
Yes.
You said it's the abnormal accumulation of proteins.
It's what is responsible for the exophthalmos,
Okay.
the protrusion of the eyeball. In the back of the eye, of course. Just like, it's a kind of mixed edema, but it's not called mixed edema. There are all these weird proteins that just accumulate in soft tissues. And that is what is responsible for exophthalmos. You know what that is, right?
Yes.
Okay. Now, what do you want me to write it?
No.
Okay. Now, hyperthyroidism and thyrotoxicosis are not the same thing. And you need to be very clear in your mind what they are. Thyrotoxicosis is clinical manifestations of thyroid hormone excess in the body. That's what thyrotoxicosis is. It does not matter where that thyroid hormone is coming from. If you have clinical evidence of excess thyroid hormone in your body, you're thyrotoxic. Whether you ingested it in overdose or somebody gave it to you in injection, it does not matter. Thyrotoxicosis simply means you have clinical evidence of excess thyroid hormone in your body. Now, hyperthyroidism is a state of hyperfunctioning thyroid gland. So, hyperthyroidism is a cause of thyrotoxicosis, but not the only cause of thyrotoxicosis. You got that? Okay. So, hyperthyroid patients are thyrotoxic, but thyrotoxic patients are not necessarily hyperthyroid. Okay? And then, pre-tibial edema is specific for the hyperthyroidism of Graves' disease in a thyrotoxic patient. It's called Graves' dermopathy. Why do we call it out? Because generally speaking, pre-tibial edema is supposed to be a sign of hypothyroidism. You're not supposed to see it in hyperthyroidism. The only time you see pre-tibial edema in a patient that is hyperthyroid is when they have Graves' disease. And that is why we call it Graves' dermopathy. Very important. You can see goiter in hypo and hyper. You can see pre-tibial edema in hypo and hyperthyroidism. But in hyperthyroidism, pre-tibial edema is only seen when that hyperthyroidism is due to Graves' disease. And in that case, it's usually called Graves' dermopathy. Very good? Excellent. So what are some of the causes of thyrotoxicosis without hyperthyroidism? Thyroiditis. So if you have an inflammation of the thyroid gland and you kill the thyroid cells, and the thyroid cells, because they died, they release the thyroxine that was in them, well, that thyroxine is going to end up in the circulation, and your patient will be thyrotoxic, right? If you have somebody with goiter and you expose them to iodine excess, you end up thyrotoxic, right? It's not because the thyroid is hyperfunctioning, but it's a huge factory that has been depleted of resources for a long time. Now you just give it the raw material it needs. Just doing its normal work, you will make excess thyroid, and the patient will be thyrotoxic, right? And then in somebody that is just ingesting thyroid extract, it could be in supplements, it could be in pills, for whatever reason they're doing that. It's called thyrotoxicosis factitia. How do you know it? Anytime you suspect it, measure thyroglobulin level. Okay? Anytime you suspect somebody has thyrotoxicosis factitia, measure thyroglobulin level, because thyrotoxicosis factitia is the only cause of low TG. Okay? So we just talked about thyrotoxicosis and hyperthyroidism, right? The difference is clear, right? Now, what about thyrotoxicosis and thyroid storms? Because you will see sometimes they'll say, oh, the patient is in thyroid storm or the patient is thyrotoxic. So thyrotoxicosis is just a state of hyperfunctioning thyroid gland. Thyroid storm is a severe case of thyrotoxicosis, and that severity is well described clinically. So what you have on this left side is what you would normally see in a thyrotoxic patient. And what you have on the right side is what you would normally see in a patient in thyroid storm. So in thyrotoxicosis, patient may be moody, may have tremors, may be weak, tachycardia, systemic hypertension, they might go into AND, they have heat intolerance, they may have diarrhea. Not really diarrhea, it's hyperdefecation, that's what we call it. Because there isn't increased fluidity, it's increased volume and frequency. Okay, so it's really hyperdefecation, but they start to call it diarrhea. But it's not, technically speaking, it's not diarrhea. Okay, so this is what you will see in somebody who is thyrotoxic. This is what you'll see if the patient is in thyroid storm. They become delirious, they can have seizures, they can actually go into coma. They go into congestive heart failure, they begin to flip all kind of arrhythmias. They are no longer heat intolerant, they are actually febrile. They may vomit, they may be jaundice. Again, hyperdefecation is common. Jaundice, yes. Vomiting, fevers, delirium, these are all evidence of thyroid storm. Yes, Peter.
Are the levels of free thyroid hormone 4 more elevated in a thyroid storm?
Yes, both T4 and T3, we'll get to that. Thyroid storm, thyrotoxicosis, hyperthyroidism, the biochemical profile is the same. So the description of the patient as hyperthyroid, thyrotoxic, and thyroid storm is not based on any difference in biochemical profile. The biochemical profile, the lipid profile will be exactly the same. It is the manifestation clinically that we're talking about here. You got it? Excellent. So how do you evaluate hyperthyroidism? Again, you measure TSH. So you measure TSH. If TSH is low, right, then you measure free T4. If your free T4 is high, you have thyrotoxicosis or you have hyperthyroidism. Okay? Now, I'm going to just share this with you because this is the reason I really like this diagram. Whoever did it knows what they're doing. When you see somebody with thyrotoxicosis, one thing you always want to find out is this Graves' disease or is this something else? Remember in hypothyroidism, you want to make sure whether or not it is Hashimoto. And what do? You measure TPO, right? Antibodies. In hyperthyroidism, when you see thyrotoxicosis, you want to rule out Graves' disease, right? And there is a way you can actually look at, you can actually measure the thyroid stimulating immunoglobulins, but it's very expensive. And if you're working in a low income place, you may never be able to do it. But there is a way you can actually assess and still figure out Graves' disease. You look at the ratio of free T3 to free T4. That ratio is very important. If that ratio is more than 20, your patient has Graves' disease or toxic multinodular goiter. If it is less than 20, you're dealing with somebody who is ingesting thyroid hormone or an impotent thyroid. Okay? Why is this the case? Because Graves' disease releases a hell of a lot more T3s than T4s. Okay? And that's why it's really very dangerous disease. So it is very simple. Measure TSH. TSH is reduced, that is your indication right there for hypothyroidism. Then when you're free T4, that is what is responsible. Then that is thyrotoxicosis, and then you move on. If your T4 is normal, some people say you should measure free T3. It's a waste of time. Because why would you measure T3? They say if T3 is elevated, then that means you have T3 toxicosis. What the heck does it matter? Whether it's T3 toxicosis or T4 toxicosis, I'm going to treat the toxicosis. And so this one is, put a circle around it, and put question mark. Because technically speaking, whenever you see reduced TSH and normal T4, that is your subclinical situation, right? So it's more subclinical hyperthyroidism, and there are a bunch of other stuff that will cause non-thyroid illness. You will never include this in practice because the truth is, when somebody is ill, you don't do thyroid function test, right? So if you follow the rules, you don't have to worry about this. Pregnancy is obvious. So whenever you have abnormal TSH with normal T4, that is a subclinical subclinical situation, depending on what the levels are. You got that? Okay. You know, you had a question?
Let's say they had a tender thyroid gland, you
Mhm.
wouldn't have to rule in, you already ruled out Graves and ruled in
Yes.
thyroiditis, so you wouldn't have to ratio test.
I don't understand.
Because you said if they have a tender
If thyroid is tender, thyroiditis.
thyroid.
Yeah. And if you do the test, the patient might be thyrotoxic, but if you do the test, you find out that many, many times TSH will be reduced. Your T4 may be high. In fact, thyroiditis could look just like the patient is thyrotoxic. That's why I said, if you miss tenderness, you will misdiagnose thyroiditis as thyrotoxic or hypothyroid. Okay, just remember that thyroiditis is hypothyroidism with a tender goiter. Okay? If you find TSH to be elevated, that means your PT3 is driving the thyrotoxicity. So that's a secondary hyperthyroidism. So there is a TSH secreting tumor. Okay? And I put a box here to remind you that thyroiditis releases stored thyroxine. And thyrotoxicosis injects exogenous T4. Again, to remind you. Okay? Are we good? You know. So now, let's say you decide that your patient has hypothyroidism. Right? Remember, what are the two differential diagnoses of thyrotoxicosis? Graves' disease and toxic multinodular goiter, right? You like to be able to tell the difference between Graves' disease and toxic multinodular goiter. Because if it is a nodular goiter that is hyperactive, you want to know it because you have to treat it differently. So how do you tell them apart? Or somebody has an extreme, severe thyroiditis and they are so thyrotoxic and they are not as tender as you think they should have been. So you're no longer sure whether this is Graves' disease or this is thyroiditis. You do what is called the radioiodine uptake. Remember that T3 uptake? Okay. Instead of coupling T3 to the what is that thing called? Those substances that emit radioactive. Instead of coupling T3 to your radioactive material, you couple iodine to it, right? And you now inject it to the patient. And then you look at the pattern of, because thyroid hormone will always take up iodine. The only time thyroid hormone and thyroid gland will always take up iodine. That's what it does. It takes up iodine and makes thyroxine. The only time the thyroid gland will not take up iodine is when it is sick. So if you do radioiodine uptake and the uptake is low, then that means your patient has thyroiditis, or your patient is injecting thyroxine. Okay? Because when you're injecting thyroxine, what happens? You suppress TSH. Once you suppress TSH, your thyroid gland becomes less active, right? So it makes sense. So if you do radioiodine uptake, it will be low in thyroiditis. It will be low if somebody is ingesting thyroid gland, a thyroid hormone. I'm speaking too much this morning. Or you have iodine-induced thyrotoxicosis. Why is the radioiodine uptake low when you have iodine-induced thyrotoxicosis? Because the thyroid gland is already saturated with iodine. So there's no room for the radioiodine you're giving because the thyroid gland is already saturated with the iodine. Okay? What are you looking for? You're looking for a high uptake. A high uptake that is diffuse, like this. These are grapes do. If it is a toxic adenoma, you get this kind of uptake. Sorry, toxic adenoma, right? Focal uptake, if it's toxic, multinodular goiter, you have this uneven kind of uptake. So this is what we do. We do radioiodine uptake only in patients with hyperthyroidism. Remember that. Don't let anybody confuse you with that. There is no reason to do radioiodine uptake in hypothyroidism. Okay? And radioiodine uptake is low when the circulating level of iodine is high as with yada yada yada. Not just extra for you. So how are we going to treat this stuff? Hyperthyroidism. It depends on how the patient presents. If the patient presents with just hyperthyroidism, you take your time, you evaluate, you treat the cause. If your patient presents in thyrotoxicosis or in thyroid storm, you control their symptoms, then you treat the cause. So, right over here, you have medical treatment in somebody who is symptomatic, that is thyrotoxic, may even be in thyroid storm, versus somebody who's just hypothyroid. I'm going to knock off hypothyroidism. Somebody's hypothyroid, block the thyroid hormone production. And the medications we used to do that are known as thioamides. You talked about this in pharmacology, right? Good. Carbimazole, methimazole, PTU. What is the difference between them? Carbimazole and methimazole, they inhibit thyroid hormone production. PTU inhibits thyroid hormone production, plus inhibits the peripheral conversion of T4 to T3. Okay? So, what do you watch out for? Granulocytosis, low white count, especially the neutrophils. Why do you care about that? Because you predispose your patient to infection. While you're chasing thyroid, sepsis will take your patient out. So that's why you have to monitor the white count. Okay? Outside of the United States, in poor countries, migrate with potassium iodide, potassium perchlorate, or lithium. Would you give anybody lithium for thyroiditis? But that's what some people have to do in some countries. Because it's cheaper to get lithium than carbimazole. Okay, just know that. Now, if you have your patient presenting with symptoms, you control the symptoms. What are the dangerous symptoms of thyrotoxicosis? The arrhythmias, the tachycardia, because tachycardia compromises diastolic filling and coronary perfusion, right? So you cannot watch a patient that is having sinus tachycardia like in the high hundreds and say you're waiting for the, because these medications, carbimazole, methimazole, these thioamides, they don't start working immediately. It takes at least 2 to 4 weeks to start working. So you need to control the symptoms. And what we do normally is beta blockade. You give them beta blockers to control the heart rate. If your patient is asthmatic, you give calcium beta blockers, right? Remember that? We've said that so many times now, right? Once your patient is thyroid is controlled, you discontinue your symptomatic treatment. Very important. Okay? Now, there is radioactive radiation treatment for goiters. When do you use it? When you have toxic multinuclear goiter, you have Graves' disease that relapses after you give dynamite. You give radioactive iodine treatment. Okay? Of course, you know you cannot give it to somebody who is pregnant, right? And if somebody has thyroid eye disease, you have to be careful. Because in your bid to control the exophthalmos, you can make them blind, right? So if there is excessive prominent eye disease, you have to be careful with radiation therapy. But generally speaking, radiation therapy is reserved, really, radioactive iodine is reserved for toxic multinuclear goiter. Okay? How about surgery? When do we do surgery? You do surgery when you cannot do medical therapy, right? And this goiter is so huge and disfiguring. Because remember, radioactive iodine will only burn the thyroid gland, it will not shrink it. If you give dynamites, they will control the symptoms, the goiter is still there. So when the goiter is big and disfiguring, you're probably better off with surgery. The problem with surgery is that many times surgeons cannot estimate how much of the goiter to take out. So they will take the whole thing out, and your patient will become hypothyroid. And then they have to take thyroxine for the rest of their life. I like radioactive iodine therapy because guess what? Your patient becomes euthyroid 90% of the time after the first dose. Okay? There is a risk of hypothyroidism as well, but it's not as common as in surgery. Okay? So you see, it's very simple. You medical radioactive iodine surgery, and you know when to use what. Yes.
Verify you said that it's that RAI is reserved for TMNG, but then it's also for relapse Graves' disease.
Yes. So primary indication is toxic multinuclear goiter. But if you cannot do medical therapy, also for Graves' disease, when the disease relapse after medical therapy. Right? Okay. Any more questions? Very good. So how do you manage thyroid storm? That is an emergency. Okay? So what do? You give glucose iodine. Why do we give glucose iodine? It blocks additional release of stored hormone from the gland. Then you give anti-thyroid agent. Specifically, we use PTU. Methimazole if you don't have PTU. Why do we prefer PTU? Because PTU inhibits the conversion of T3 to T4. So you arrest it fairly quickly. Whereas methimazole will take some time to block the release of T4. You give steroids to just calm things down. And in addition, steroids also block the conversion of T3 to T4. And then you give beta blockers. Okay? That's how you treat thyroid storm. Beta blockade, PTU, steroids.
Dr. Martin, say what you said about PTUs again. I missed that.
PTU, it blocks the release of thyroid hormone from the thyroid gland, plus blocks the peripheral conversion of T4 to T3.
Okay.
Remember, T3 is the active form of thyroxine.
Yeah. Okay.
Are we good? Yeah.
If you had hyperthyroidism, how often do patients present with thyroid storm? So I assume they go to the ER, right?
They will, the patients around to the emergency room or call 911. Thyroid storm is crazy. You see them shaking, sweating. Some of them have seizures or become acutely confused. And it's an emergency in a real sense of it. And the good thing is that it happens when patients have been hyperthyroid for a long time or thyrotoxic for a long time and they ignore it. Instead of coming to the doctor, they go to the Santeros. And then they go crazy in the Santeros house, then they rush them.
Usually kind of a smaller insidious concept.
You can't predict it. It could happen 6 months, 6 weeks, right?
Are you likely to have a recurrent episode of a storm?
No, most of the time, patients that present with thyroid storm get treated permanently in the hospital because they always end up in the hospital. Thyroid storm will put your patient in the hospital. And most of the time, they will not be let go of the hospital. Either they get surgery or they get radiation interim. Right? You know what Santeros are? All right. Again, I'm just telling you other causes of hypothyroidism and what you can do about them. TSH producing tumor, take it out. Struma ovarian, take it out. Choriocarcinoma, take it out. Somebody is ingesting thyroid hormone, talk to them. Are you crazy? Why you keep doing that? Then maybe they will listen. Right. There is no specific treatment for thyroiditis. So once you diagnose thyroiditis, you just observe. You see why it's important not to miss it? If you miss it, you will diagnose the patient as hyperthyroidism. You will sentence the patient to methimazole for life. You will make them sick. You will cost the system money for something you could have just watched. Because thyroiditis is a viral illness like laryngitis. It goes away by itself. Even if the patient becomes thyrotoxic, treat the symptoms of the thyrotoxicosis and leave the patient alone. They will recover. Usually 2 to 3 weeks. They'll be gone.
So now, thyroid function test, is it similar? How can you tell the difference? Besides when you examine an account, can you tell the difference in the profile?
I just told you. The profile
The ratio.
in every hyperthyroid patient is the same. It is clinically that you can tell when it's thyroiditis. The ratio does not really help you to tell if you're well, it does. If you have T3 to T4 ratios and it's more than 20 and less than 20, but it does not confirm so it does not confirm thyroiditis. There are other stuff that can give you that less than 20 ratio of T3 to T4. Right? All right, so one other condition that you will see in practice that you need to know about is sometimes patients will come to you and you see a nodule. Just a thyroid nodule. And you're like, what am I supposed to do with this? So somebody present with a thyroid nodule. It could be this small and it could be this big. Both of them are, this is a nodule, this is a goiter. Nodule, goiter. The difference between nodule and goiter is the size. Both of them are thyroid enlargement. Okay? What causes it? Look, I just told you, Graves' disease and Hashimoto can cause it, autoimmune disease, iodine deficiency in endemic regions. But why do we worry about it? It could be neoplastic. Okay, that's why we worry about it. It could be benign, as in a thyroid adenoma or a thyroid cyst, or it could be malignant. When it's malignant, most of the time it's papillary carcinoma, 60% of the time. All right. Then follicular carcinoma, 25% of the time. Then anaplastic, 10% of the time, and medullary carcinoma, 5% of the time. That is why we worry. This nodule here could be cancerous. So once you see it, you can't sit on it. The first thing you do is do a thyroid function test, right? But before you even do a thyroid function test, before you do any test, you will talk to the patient to find out what is the probability that this could be cancer, right? So you assess your patient cancer risk. Has the patient gotten any head and neck radiation before? Is there any family history of cancer, right? Does the patient have a personal history of cancer? If all of these are positive, your risk, the probability that this could be cancerous is high, right? Then you look at the patient's thyroid function states. Patient is euthyroid and they're from somewhere else. This could be an endemic goiter, right? But more likely not to be cancer. Patient is hypothyroid, it could be Hashimoto's disease, right? If your patient is hypothyroid, it could be Graves' disease. If it's a non-functional, in other words, your patient has a nodule and thyroid function is normal, you worry. That is when you do technetium 99 scan. When you do technetium 99 scan, and you could see this area where the technetium 99 is like the thyroid gland picks it up like it picks up iodine, okay? And you see this portion, this is normal thyroid gland. This portion here is not normal because it's concentrated in technetium more than the surrounding tissue. You call that a hot nodule. A hot nodule is a good thing because that means the tumor is active. You can cut it out, you can burn it off, right? This is what you worry about. When all of the thyroid gland takes up the technetium, but the nodular area did not take it because he has very bad intention. And that is called a cold nodule. Okay? So cold nodules are bad things in thyroid scan in somebody with goiter or thyroid nodule. Okay? Some people say we can do ultrasound. It's not reliable, really. The only time you will do ultrasound is if you intend to do fine needle aspiration, which is a kind of biopsy, right? You do ultrasound guided aspiration. That is the only time you use ultrasound in thyroid nodules. You don't use thyroid ultrasound to evaluate a goiter. No. You use ultrasound to do fine needle aspiration. Okay, don't get confused because I can see how somebody will want to see whether you know what to do with ultrasound in somebody with goiter. Okay, that is that. If the size is less than 1 centimeter, generally you wait and watch. If it's more than 1 centimeter, you will do fine needle aspiration. Please, again, I want you to remember what I said. You want to find out whether the nodule is hot or cold, you do a technetium 99 thyroid scan. You find a cold nodule, you use ultrasound to measure the size of it after you have found it. You don't use ultrasound to explore the goiter. After you have found the nodule, you want to measure the size of it, ultrasound. Less than 1 centimeter, you can watch and wait. More than 1 centimeter, you do fine needle aspiration. Let me ask you something. If your mother had a cold nodule, would you wait for 1 centimeter or less than 1 centimeter or greater than 1 centimeter? Thank you. So you see a nodule, biopsy the nodule. No, why are you waiting for 1 centimeter? What difference does it make? Just biopsy it, right? Because before you get to 1 centimeter, it may have spread also, right? Although the probability is less, yeah, but who wants to take that kind of chance? Okay, what you won't do to your loved ones, why are you doing it to somebody else? Okay? All this is where I kind of I disagree with many of these policies. All right, so this is how then do you treat a thyroid nodule? It's very simple. This is just an overview of everything we talked about already. Palpating nodule, discover the nodule, you take a history, you assess the risk. If the patient is hyperthyroid, you send them for hyperthyroid treatment. You can do radiation therapy, you can do surgery, we already talked about that. If your patient is not hyperthyroid, is the nodules by itself, no risk factors, you do fine needle aspiration, regardless what, again, put a circle here and put a question mark. Because you know what, all this stupid 1 centimeter, 2 centimeter is nonsense. Once you find goiter and your patient is not hyperthyroid or hypothyroid and TSH is normal, immediately you're going to do a scan and you're going to do a fine needle aspiration to find out what the heck is going on. Okay? And generally speaking, after you do surgery, you monitor TG, thyroglobulin levels. That is how you can like monitor the efficacy of the surgery that you just did. Okay? Good. Are we clear?
Dr. Martin.
Let's see. Yes.
I missed what you said about like non-functional. When you say non-functional, are you saying like the thyroid?
Thyroid gland is normal. In other words, the thyroid function test is fine.
Yeah. So what? What's the difference between that and like it being euthyroid?
Yeah.
So like the
that's what it
patient,
is.
so the patient has a goiter.
Yeah.
For the first one, I seen like in the patient's euthyroid, right?
Yeah, that is something that's been.
As the non-functional.
Yeah, yeah.
Oh, okay, okay,
Yeah.
okay. So like.
But be careful how you use that word. When you see goiter,
Mm-hmm.
you do thyroid function test.
Yeah.
Right?
Mm-hmm.
If your patient is hypothyroid,
Mm-hmm.
that already gives you an idea. That could be Graves' disease, could be toxicosis, could be anything else. But if your patient is euthyroid,
Yeah.
right?
Mm-hmm.
Then you now do the technician scan to see,
What's
to
going on?
identify a cold nodule.
Okay.
If you find a cold nodule, sometimes somebody can argue that if your patient is euthyroid, why do you want to do
A scan.
a scan?
Yeah.
And it makes sense because the reason we do scan is to say whether this is Graves' disease or multinodular.
Yeah.
If your patient is euthyroid, that is less likely. And that is the reason if you see in that diagram, they recommend actually going to do fine needle aspiration straight if your patient is euthyroid.
Euthyroid. Wow.
Yeah. Good
Okay.
question.
Okay.
Good.
Thank you.
All right, let me see how much of this you really grasp. So here is this 28-year-old female with no significant past medical history, presenting with difficulty losing weight in spite of severe dieting after her last childbirth 6 months ago. She said it was a normal spontaneous vaginal delivery except that she bled a lot. Physical examination is unremarkable except for a body mass index of 34, so she's obese, borderline morbid obesity. So which of the following findings will be unlikely in this patient? Christian, what wouldn't you expect to find in this patient among this list?
The breast TSH level?
What do you think? What do you think is going on
Because she
here?
has that condition where she.
She has, right?
Yeah. If she has.
If she has she hands, will she ever be able to give you a limited TSH?
Sorry.
If the pituitary is gone, she will never be able to give you a limited TSH. You got that?
Mm-hmm.
Wendy, which of the following statements about Hashimoto's thyroiditis is false? Is that autoimmune disease? Is that true or false? It is the commonest cause of hypothyroidism. It can be associated with thyrotoxicosis. Huh? Haven't you heard about Hashimotoxicosis? Wendy, talk to me. I'm talking to you. It can be associated with thyrotoxicosis. It is usually associated with TPO antibodies. It is never associated with thyroid.
That's false.
Exactly, because it can be, right? All right. Eden, this 26-year-old female, no significant past medical history, present with a tender anterior neck mass following a brief upper respiratory illness 2 weeks ago. What does she have?
Thyroiditis.
Thank you.
So C, increased radio. Unlikely would be the increased radio iodine.
Thank you. Good. You got that? She will have depressed TSH because in thyroiditis you release preformed thyroid hormone, right? She will have elevated thyroid hormone, yes, because they are released from the dead and dying thyroid cells. She will not have increased uptake because a sick thyroid does not take off radioiodine. Okay? Increased globulin level, yeah, positive TPO, maybe, but you will never have increased radioiodine uptake. You understand that?
Mm-hmm.
Okay. Don't memorize the answer. Understand the concept.
So we're thinking thyroiditis because she had a brief respiratory illness?
Exactly. And then the tender anterior neck mass. The tender anterior neck mass is an enlarged thyroid. Okay? That moves with deglutition. Yes.
Sorry, what did you say is, for an A, it actually, produces preformed?
Preformed because the thyroid gland is inflamed. So the thyroid cells, some of them are dying, some of them are dead. the thyroxine in them gets released. And that suppresses TSH. So that released the preformed, already existing thyroid hormone that is released with the inflammation goes and suppresses the TSH at the PT3 level. Got that? Excellent. Abby?
Sorry, Dr. Murphy.
Yes.
For the last question, so do they have TPO antibodies?
Yes.
Chris.
Normal people can have TPO. Up to 15% of female will have TPO. So TPO does not tell you anything. Right? Okay? Annie, all but which of the following would be suggestive of thyroid cancer in a patient with a thyroid nodule? All of the above. Thank you.
It's not
Annette.
none of the above.
Yes,
Oh.
It's none of the above.
it says all but which one?
All but which? None
So
of the
which
above.
one, yeah.
I need to get rid of this question. I go through this every single year. It's badly worded, right? All but which will be suggestive of cancer. All but which? None of them, right? All of them will be suggestive of thyroid cancer. All right? Yeah. Thank you. I should simply get rid of this. Say which one of the following will be suggestive of thyroid cancer. Yeah. There are all but, some that just like to be sophisticated and they complete everybody. I need to go in on those two. But you understand it now, right?
Yeah.
So you're asking for which one to?
Yes, exactly. Exactly. So it's none of them, all right? Okay, so let's do this one. Annette. Thyroid globulin level is high in Graves' disease. TSI are responsible for all thyrotoxicosis. Thank you. Hot nodules on thyroid scans are hypothyroid. TPO antibodies are rare in hypothyroidism. Cold nodules are more likely to be malignant. Graves' disease is a common cause of fever. That, not Graves' disease, thyroid storm is, right? Thyroid nodules, more than one semester, only need to be observed. Medullary carcinoma is a cancer of the C cells. Thank you. Right now, let's take a look at this. This is a thyroid panel, okay? It's missing T3 resin uptake. So let's start with Justin. So here is a patient with a low TSH, normal T4, and normal free T4. What's going on here? Low TSH, normal total T4, and normal free T4. I give you a clue here. FT4 is responsible for frequent manifestation of thyroid disorder. I'm going to give you another clue. Whenever you see TSH and free T4 in opposite direction where you have abnormal T4 and abnormal TSH, that's a subclinical situation. Right? Good. So, what is going on? I've given you the clues. What is going on here? So, Justin thinks this is a subclinical hyperthyroidism. Anybody think it's something else? Everybody knows why he did that? Okay. Maureen, number 2. What is this? TSH is normal, free T4 is normal, but total T4 is low. How can that be?
It's not pregnancy.
It's not pregnancy. What do you think it is? At least I'm glad you recognize that it's probably not thyroid disease, right? And you say it's not pregnancy. So what is it? Come on, you already said it's not thyroid disease, so it cannot be A, B, C, D. It can only be E or F. I said it's not E. Why are you holding me?
Liver cirrhosis.
Good, it's liver cirrhosis, right? Why do you think that happens? Because in liver cirrhosis, you cannot produce thyroid binding globulin, and that limits the capacity for your T4 that you can hold. So that is why total T4 is low, but free T4 is normal, right?
You said liver cirrhosis can,
When you have liver cirrhosis, you cannot synthesize thyroid binding globulins. And since thyroid binding globulins are your carrier for thyroxine, You can only carry as much as they can carry. If they are low, then you can't carry T4 alone. So your T4 will be low. But your free T4 will be normal. Okay? All right. So Stephanie, this third patient here has a high TSH, but normal everything else.
It's gonna be subclinical hypo.
Thank you. So that is a subclinical hypothyroidism. Right? Right? So even though 3 to 4 is normal, the patient needs more. That's why TSH is high. Right? Right? Case number 4. David. TSH is normal, 3 to 4 is normal, but 3 to 4 is high.
So is it a primary hyperthyroidism?
TSH is normal, 3 to 4 is normal. Is there a thyroid disease? So if there is no thyroid disease, what is it then, David?
Pregnancy?
Thank you. What took you so long, man?
My bad.
Okay, you're bad. Really good, man. Loss. What about this patient? TSH is low. Total T4 is high. Free T4 is high. Primary hyper. Thank you. Thank you. Last one, Ali.
So it would be high TSH, low T4, and low for T4 would be primary hypo.
Thank you. All right. So, are that the correct answers?
Yeah.
Okay. Thank you. Moving on. I want one brave soul here to take all these questions. I want a volunteer.
This is a new set.
Bradley.
We just did this.
No, it's another one. It's a different one.
Right? So, again, I'm giving you clues now. A normal free T4 in the presence of an abnormal TSH is indicative of a clinically non-manifesting, otherwise subclinical thyroid disorder. All right? Good. So, now, I'll help you. See? So, let's start with this first one. So, TSH is low, right? And free T4 is low. So, there's thyroid disease here, right? But total T4 is normal. So, think it through. Do you agree there is thyroid disease?
Yes.
Because TSH is low and free T4 is low. Something is wrong, right? What do you expect total T4 to be? Do you expect it to be normal? You don't expect it to be normal. So if it is normal, that means the patient has something that is expanding the pool of total T4 within the context of hypothyroidism. Right? So what do you think that might be? For sure it's not subclinical, right? So A and B is out.
No.
Right?
That's not clinical.
It is not secondary hypothyroidism, otherwise everything will be low, right? It is not secondary hypothyroidism, otherwise everything will be high. Is it secondary hypothyroidism in pregnancy?
Yeah.
Exactly. So that is why total T4 is high, because the base is high because of this pregnancy. You got that? Are you still brave enough to keep on, man?
I kind of understood that.
Okay. Let's do this one. This one is easier.
Yeah.
What is this?
That is secondary hyperthyroidism.
Thank you. Straightforward secondary hypothyroidism, right? How about the third case? Christian, help him out. I want you to recognize the clue. Look, right here you have a situation where TSH and
So it's low,
pretty
so
for
it's-
going, they are flipping. That tells you
normal,
what?
So it's the opposite direction, so they're subclinical.
Thank you. So this is a subclinical situation, right? The case number 3. So what subclinical are we talking about here? Is it subclinical by itself? Or subclinical with something?
With liver cirrhosis?
Thank you. Subclinical hypothyroidism with liver cirrhosis, right? So this is what gives it away as subclinical, normal free T4, and low TSH. That is what makes it subclinical hypothyroidism. The fact that free total T4 is low is not what you expected, right? That is because of liver cirrhosis. You all got this? This is complicated, right? So if you got this, it doesn't get any more difficult than this. So I'm not going to bother you with the rest of it. You can figure it out. 5 minutes break, and we'll switch gear to something else. Are you clear with this one? Your midterm is next week.